Beverly Reed.
And I'm Dr. Amber Klimczak.
And we are Two Peaks in a Pod. Well, hi guys. Welcome back. How's your week been going, Dr. K?
It's been really busy.
Yes.
But good.
Yes.
Really busy. Lots of surgeries this week.
Yes.
So exciting stuff.
Yes, absolutely. Okay, well, I wanted to run a celebrity story by you.
Okay.
So, do you know who Jessica Simpson is?
Of course. Okay.
Whoa,
I'm not that bad. Okay.
I mean, I know sometimes you're not up with all the celebrities, so I don't know which ones you know and which ones you don't know, but you're familiar with her.
Fun fact about Jessica Simpson, she actually grew up in the same town that I grew up in here in the Dallas area.
Oh, I didn't realize that. Okay,
Yeah.
That's cool. So you're like besties.
Basically. She was kind of known by some other people that I know. So
okay,
yeah, their
very
family
cool.
lived here. I think she went to Pierce High School.
Oh my gosh.
People out there listening are probably going to correct me, but I'm pretty sure she went to Pierce.
Yeah. Okay, great. Well, she had written a book about her life, and I did read her book. It was a good book. And of course, I love to hear any fertility tidbits or anything like that. And so she described in the book that she actually had to have one of her fallopian tubes removed. She says that they found a cyst on her fallopian tube, which, most of the time when we're talking about cysts, we're talking about cysts on the ovaries, but you can get cysts on your fallopian tubes too. And most of the time they're not anything that will cause a problem. But apparently this one did cause enough of a problem that she had to have the tube taken out. And she just remembers feeling really devastated when that happened. And she told her doctor, I want to have babies. Please don't take this chance away from me to have babies. And she said that he responded that because he removed her fallopian tube and just one fallopian tube, that it would mean that she could only get pregnant every other month. And but then she went on to have 3 kids. And so I just wanted to get your take on this because I definitely had some thoughts about this. So what do you think? Is what her doctor said true about only being able to get pregnant every other month if she only has one fallopian tube?
Yeah, so I get this question a lot. Yeah. When we're doing ultrasounds and people want to know which side did they ovulate from, and same sort of situation, maybe one of their fallopian tubes isn't working. So interestingly, when you have your cycle each month, and if you're ovulating each month, it's not as simple as right side ovulates, then next month left side ovulates, and then right side. Okay, it doesn't alternate like that. A lot of times what they found is that you might, ovulate from your right 6 months in a row, and then maybe your left pops in there and ovulates. So this concept of, well, if you're missing one fallopian tube on that side, and the month that you ovulate from that side, you won't be able to get pregnant, that's not entirely true. First of all, for that reason, because what if you ovulate on the opposite side 6 months in a row? That's a really easy path to pregnancy. Traditionally, when we think about ovulation, we're saying the ovary is releasing its egg, and then typically the fallopian tube on that side kind of uses these little finger-like projections to grab that egg and bring it down the tube. But there's something really interesting called contralateral capture, meaning you can actually ovulate from the opposite side, release your egg from the opposite side, and the finger-like projections from the other side come and grab that egg and capture it. So I disagree completely with what her doctor said on multiple accounts.
That's true, right? So yeah, really saying, hey, it doesn't mean that you're going to ovulate on different sides every other month. It doesn't mean your fallopian tube can't reach over and get an egg from another side. So yeah, I completely agree with it. But I do have to say too that doesn't that just fascinate you that fallopian tubes move?
Yes.
I mean, I just remember before I knew much about fertility, I just only had seen fallopian tubes in textbooks, and they're always just sitting there. They're always just like this.
Stagnant.
I had no idea that they moved until much later when I started learning about things like this. And maybe some of y'all might need to check out my Instagram too, because every now and then we can see a fallopian tube on ultrasound if there's like fluid in the pelvis or something. And you can actually see the fallopian tube moving and waving around and everything. And I just think it's fascinating because most of us just think that they're static structures that just sit there all the time. But no, they can move around.
And with some of my patients, your fallopian tubes can be really long. So I always compliment people. So we do a test called the HSG, hysterosalpingogram, where we use an x-ray to look at your fallopian tubes in your pelvis. And anytime I see long, beautiful tubes, I'm like, look at your fallopian tubes, like sometimes they're really long in your pelvis. So just think about that, can go all the way over to the other side. So certainly that's not the situation that you're going to be in if for some reason you're missing a fallopian tube.
That is so funny. I mean, I definitely compliment people when I see a nice uterus or nice ovaries. I've never complimented anyone on their fallopian tube length, but you know what? I should start.
It's funny, this week, Kennedy I had this tall, beautiful patient.
Yeah.
I think she was almost 6 foot tall.
Yeah.
And her tubes were so long. I'm like, your tubes are just longer
Beautiful.
than you are.
She has supermodel tubes.
Yeah.
I guess that's what we should call them. Supermodel tubes.
It was hilarious.
Well, okay, I wanted to kind of talk about a couple things when it comes to fallopian tubes. Part of the reason I wanted to bring up this subject is I have a lot of patients, and I'm sure you do too, that suddenly get this news that they only have one fallopian tube, and they feel very stressed out about it. And I think a big part of our role is reassurance. But first, let's talk about how we even figure out that they only have one fallopian tube rather than two. So probably the most common way that we're figuring this out is by doing a test called HSG. We commonly call this the dye test. And this is a test where we put dye into the uterus and then we take an x-ray to see, does the dye spill out of the fallopian tubes? That is our way of being able to determine if tubes are open or closed. But there are some other ways that sometimes we figure out that somebody only has one fallopian tube. So sometimes it's just as easy as history, right? If somebody tells us they've had their tube removed, or, if they've just had surgery for another unrelated reason, and maybe they checked the tubes while they were there and found out that they only had one functional tube. So there's lots of different ways that we can find out that sometimes somebody is only down to one tube. But really, it's kind of one of the things where you look at, is the glass half full or half empty, right?
Yeah.
So of course, the ideal situation is both tubes are open. But when I see that only one tube is open, I say, well, thank goodness they're not both blocked.
Right.
Such a game changer at that point. And so if we know we have at least one tube open, then we can really start talking about what kind of treatments are available. But I thought maybe we should first talk about why sometimes one of the fallopian tubes can be blocked.
Yeah, there's a lot of different causes for blocked fallopian tubes. I would say some of the more common ones: sexually transmitted infections. Chlamydia is known for just really affecting your fallopian tube. Basically, you get an infection, which is a sexually transmitted infection, and it causes scarring of your fallopian tubes. And when that scarring occurs, it can close off essentially and scar closed. And so then when sperm and egg are trying to get together, they can't meet in the fallopian tube. So I would say STIs are a common one. Surgery is another common one. For example, Jessica Simpson had something on her fallopian tube, had to have it removed. Maybe you're getting your fallopian tubes removed for other reasons. Other common things are just anything that can scar in the pelvis, anything that can cause adhesions or scarring in the pelvis. So sometimes people can have a surgery that, maybe a ruptured appendix, something that leaves behind a lot of scar tissue that can affect your fallopian tubes. Because I always say the fallopian tubes are like wet tissue paper. They're really fragile.
Yeah.
So things that you wouldn't even expect to affect them can. There's another condition that some of you may be familiar with called endometriosis. Endometriosis can cause scarring of the fallopian tubes as well. And we don't really know everything that's involved in endometriosis, but probably another common cause of fallopian tube dysfunction.
Absolutely. And certainly too, a common reason we'll be doing an HSG is sometimes a patient will tell us she's had an ectopic or a tubal pregnancy before. And sometimes those can be treatable without needing surgery, but then they just want to know before they try again, why did they get the ectopic? Do they have damaged tubes? And so sometimes we'll find out that way too. Or sometimes they needed surgery and they had their fallopian tube removed and they, want to see if the remaining tube is open as well. So but I did want to touch on the very first one that you brought up, which is the sexually transmitted infection. Certainly, we know that this can produce a lot of tubal scar tissue, but I just feel so bad because have you noticed there's just so much shame that women feel when it comes to this, and it just breaks my heart. And I just wanted patients to know from Dr. K's and I perspective that, we see this all the time. Like as a patient, you probably feel like you were just the only one in this situation, but it's actually really, really common. We were actually talking to somebody else the other day about the different reasons why there's an increased need for fertility treatment. And one of the things came up is that sexually transmitted infections are actually at an all-time high right now. And the reason for that is these days we have very reliable long acting contraception, which is great. This has resulted in the lowest teen pregnancy rates we've ever seen. But the problem is when you have reliable contraception, there tends to be less use of condoms. When there's less use of condoms, that means that you can be more prone to getting sexually transmitted infections. And you may have had chlamydia and known it, or you may not have known it even. So a lot of people have no symptoms of it at all. But we just want to reassure our patients that it's really common. There's no judgment here at all. Just think if you knew somebody who got strep throat, you wouldn't judge them, right? That's kind of how it is for us. If we've seen a patient that had chlamydia, it's like, okay, like these things happen. But it is helpful for us to know about that history. But the other thing too is there may be awkward moments that come up, like maybe you had chlamydia before with a prior partner and you don't want your current partner to know. And the thing is, you can always reach out to us and let us know if you want to talk about those things privately or personally away from your partner, because we just want you to feel safe and secure in a moment like that.
Right. Here's the reason why it's important for us to know. So we talked about there's different causes. Well, if we do the testing, say in HSG, and we notice that one of your fallopian tubes is not working properly, well, then we're kind of running through all of these possible diagnoses in our head, and there may be other things that make us suspicious that you might have endometriosis going on, and it might lead us down this path. But if you're like, no, I definitely had chlamydia, I remember getting treated, it kind of sometimes makes us think, okay, that's the reason for tubal dysfunction, and we don't go down this other path. So it is really important information for us.
Yeah. And certainly too, sometimes you can have multiple causative factors, or kind of even some more rare ones too, is sometimes we'll get patients who have inflammatory bowel disease, Crohn's disease, other reasons that you can get inflammation in scar tissue. But I think the hard part is a lot of the times we cannot find a reason. So sometimes you have a blocked tube and we just don't know why that is. And that's okay, because it doesn't mean that we can't still treat you. But I do feel that it can be a little bit frustrating on the patient side of things when, you just want a reason,
right?
And then I do think the other thing we should bring up too is that sometimes you can just have a false positive on your HSG test.
That was something I was going to mention. I think it really depends, and something you should pay attention to when you're getting these sort of tests is, okay, where was the blockage that they saw in the fallopian tube? And sometimes this may kind of go over your head, or you may not have been paying attention to it, but there's lots of different ways that your dye test or your HSG could be abnormal, showing a blocked fallopian tube. So if you can imagine, your fallopian tubes start at the beginning, the top of the uterus, and they come down. So one option might be that your fallopian tubes filled with dye all the way, but then are just blocked at the end. Okay. And so we call that distal, or the far end. Okay. Blockage, obstruction. Or you could actually have a blockage right at the very beginning part where it's closest to the uterus. And I would say that's called proximal versus distal blockages are very different to me, and I interpret them very differently. And the other thing to kind of consider is sometimes your tubes look really skinny still on the HSG, but there's no dye spilling out. Or sometimes your tubes can look really swollen like a big balloon and there's no dye coming out. Those are also very different pathologies that are going on, and something to kind of pay attention to.
Absolutely. So can we use your arm as a fallopian tube?
Yeah.
So this is the fallopian tube. Dr. K is the uterus. So the part of the tube closer to the uterus is proximal, and then this would be distal here. And I think that's such a good point about how we just interpret that so much differently. And I think it really matters in terms of factors for success as well, where if the blockage is up here, if it's proximal, sometimes that can just be a false positive because there is muscle around that portion of the fallopian tube. And it is not uncommon to get a little tubal spasm there.
Just clamps down and closes and doesn't let that dye get through.
Yeah. And so when we see that, I think we're almost happy. Of course, we'd prefer the tube be open, but if it's going to be blocked, we'd rather it be blocked there than at the end.
Absolutely.
If it is blocked at the end, that tends to be more likely to be a true blockage, and one that does have more of a poor prognosis is what I would say about that. But I also think you brought up a really good point about if the tube is very skinny versus if the tube is really dilated with the dye. So that is called a hydrosalpinx if you have a really kind of dilated, stretched out tube. And that is really important because if you have a hydrosalpinx, that fluid that can accumulate in the fallopian tube can spill back into the uterus when you're trying to conceive, and it can actually work against you. So that fluid can be toxic to an embryo, it can prevent implantation, or if it does implant, it can contribute to miscarriage. And so if somebody has a blocked tube and it's a hydrosalpinx, you really need to have that fallopian tube removed in order to have optimal chances of conception.
Absolutely.
I think that was a really good point to bring up because I did have a patient bring up to me the other day. She really kind of thought both those things meant the same thing, that a blocked tube is the same as a hydrosalpinx. Yes, in both cases they're blocked, but in one with the hydrosalpinx, you need to have surgery to remove the tube. In the other one, if it's just a blocked tube, you don't necessarily need to remove the tube, even if it's blocked.
Right. Yeah.
Yeah. Okay, so I wanted to know if you have a patient that has one tube that's open and one tube that is blocked, and they ask Dr. K, can I get pregnant naturally? What do you tell them?
Yes. Simple answer, but I would say there's a little bit of, some asterisks after this. So can you get pregnant with one fallopian tube? Absolutely. And my recommendations for how to get you pregnant maybe will vary depending on what's wrong with that tube, just like we were talking about. But let's just say, for example, you have one tube that's blocked approximately close to the uterus and the other one's open. I think that's really an ideal situation. You could continue to try and conceive on your own. We could consider something like inseminations to try and get you pregnant because there's not a whole lot of risk with that sort of blockage as opposed to some of the other blockages. But if you have one functioning fallopian tube, regardless of what's going on with the other one, you can always have a chance of getting pregnant. And something to consider, which I know we're going to talk about also, is that there is a chance that you get pregnant on that side with the dysfunctional fallopian tube as well, which will lead to a higher risk of ectopic. And sometimes, depending on the blockage, I might think that there's a higher risk than other times.
Absolutely. And I think too, most of the time when we're seeing a patient in this situation, they have been trying on their own already. And so in those cases, we're oftentimes are recommending some more aggressive treatment than just trying on their own. But sometimes we'll get cases where, kind of back to that example where maybe somebody had an ectopic pregnancy, they had one tube removed and they were told to see us to evaluate the other tube. In a case like that, I may say, hey, why don't you try maybe for 3 months on your own and see how it goes. And sometimes just knowing if somebody got pregnant naturally on their own or not can really just help us know if we need to be looking for other things too. So, for example, you brought up endometriosis. Well, endometriosis can affect your fallopian tubes, but also a host of other factors in the pelvis. And so I think really we're always looking for these hints whenever we're doing ultrasounds or whenever we're doing an HSG of all the possible sources that could have caused any tubal scar tissue or anything like that. Okay, I have a common scenario I want to ask you about. So let's say I'm recommending a treatment that I would commonly call Clomid IUI. I've put the patient on fertility pills and my plan is going to do an insemination for her. And let's say her right tube is blocked, but she grew 2 beautiful follicles, which hopefully have beautiful eggs in them, on her right side. And she says, Dr. K, should I cancel the cycle because my eggs are on that side? What would you recommend?
I say no. So this is going back to what we were talking about with the data with contralateral capture. I think it's reasonable to still try because remember, your right ovary could ovulate both of those eggs, release both of those eggs, and your left fallopian tube could come over and grab them, and you could have a successful pregnancy. Now, I will say that patient does need to be appropriately counseled that your right fallopian tube might capture those eggs. And if there is tubal dysfunction on that right side, you are at a higher risk of having an ectopic pregnancy. So certainly something to consider, but I don't think it's a reason for cancellation. How do you handle that situation?
Yeah, I agree. I think something else that's kind of a cool concept too is when the eggs ovulate, oftentimes they're mixed in with fluid and that fluid will just kind of float behind the uterus. And so, yes, the fallopian tubes are competing with each other, sweeping through that fluid to try to get the eggs. And I think it's hard because if I got to choose with somebody who has one open tube, I'd almost rather not have a bad tube on the other side, because then that good tube has nothing to compete with, right? It's the only one trying to sweep, right? But it is hard when you've got a bad tube to compete with, because if the bad tube wins and grabs, one or both of the eggs, then certainly it can increase risk for ectopic. And I do think most women who've had an ectopic before too are aware that your chances for having an ectopic can go up. If you've had one, you're at higher risk of having another one too. And that's why I think it's just so important in these cases, as we do for all patients, to just make sure we're monitoring very early on. We're following pregnancy hormone levels. We're doing early sonograms. Even with those, we don't always pick them up early. They're very difficult when you pick them up early, but it's always good that for the patient to have really good return precautions too, to just know, hey, if you're feeling pain, don't try to be a hero. Go to the ER and get checked out, so that we keep you safe in that circumstance as well.
I think another sort of scenario that comes up is someone who's had an ectopic pregnancy previously, and they had that whole tube removed on that side.
Yeah.
Sometimes they'll come to me and say, but I got that side out. I'm not at risk of having an ectopic pregnancy.
Yeah.
And that's not the case. So when you had a previous ectopic pregnancy, there was probably a reason for that, indicating that you have tubal dysfunction. You don't have tubal dysfunction just on one side. It probably means your other side was also affected, and you have that increased risk, even with your fallopian tube that remains that didn't have the prior ectopic. So something to consider.
I think that's a really good point too, because sometimes patients will say, well, my doctor looked at my tube and they said that remaining tube was normal. But remember, they're only looking at the outside portion of the tube, but the inside could certainly have damage to it that we would not necessarily be able to see. You could even have a normal HSG and still have damaged tubes that we may not be able to see too, if the damage is on a microscopic level and is really just more a dysfunction of getting the fertilized egg or the embryo to be able to get to the right spot. So absolutely. Yeah. I will say that sometimes I've had patients who've had an ectopic pregnancy, and sometimes it can feel traumatic, and they may say, I don't want to try naturally. I don't want to try IUI. And that's okay. I have patients right now undergoing IVF for that purpose, because then they know that their chances for having an ectopic pregnancy are much lower. Now, it's not impossible. You can still have an ectopic pregnancy when you do IVF. Even if we put an embryo in the uterus, it can still bounce around and wander off to other places, but much lower chances when compared to trying IUI treatment.
And we should explain the reason why IVF is considered to lower that risk is what we do with IVF is we have you take medications to grow multiple follicles, and then we actually take the eggs out of the body and we do the insemination in a lab with sperm and then grow embryos. So normally in your body, we rely on the fallopian tubes for that fertilization to happen. But with IVF, we're taking the eggs out of the body and doing the fertilization there, and then we return the embryo back into the uterus. So we're kind of bypassing the fallopian tubes where that dysfunction is. But like Dr. Reed said, when we put the embryo back into the uterus, we're hoping it stays there in the uterus, but sometimes it can kind of migrate into a tube.
Can still happen. Absolutely. Okay. So usually whenever we give that information to a patient, you've got one tube blocked, you have one tube open. Of course, they feel stressed out and they go home and they Google. And look, I love Google. It can be a great source of information, but I have found this is one area where there's a lot of sketchy people out there trying to trick you into paying for ways to fix the problem that just are not true and not valid. And so I wanted to get your opinion on some of these.
Okay. I don't even know if I've heard all these.
What do you think of fallopian tube massage or pelvic massage to fix a tube that is blocked?
Okay, let's clarify. If you're going to massage the fallopian tube, is someone doing surgery and putting their hands into your body, or this is from the outside?
This is from the outside.
And they're rubbing your abdomen.
Yeah, pretty, yeah. Okay. Yep.
And you're paying someone to do
this. Yes, yeah.
Sounds a little strange.
Yes.
To make sure that I'm on the same page.
Yes.
Okay. I would say definitely I would not recommend that. And also probably don't go see these people wherever they are and let them rub your abdomen.
Yeah, so that is just not the case. And here's the thing. When you have operated on people like Dr. K and I know, you realize that this scar tissue is tough scar tissue. This is not something you can massage away. I tried to think of an analogy. This is what I came up with. It may not be a great analogy. So imagine you take one of those big metal mixing bowls and you put a bunch of spaghetti noodles in there, That's your intestines. Okay. And then let's, throw some golf balls in there. those can be your ovaries or whatever. That's how the pelvis is. We've got a lot of stuff sitting in there. Okay. But then imagine I pour super glue in there. Okay. And I let it dry. That is what scar tissue is like. So imagine if I tried to massage the noodles away from the golf balls, and no, that's not going to work. That's going to tear the noodles.
Yes, that's what I was going to say.
It
The tubes
doesn't.
are too fragile.
It doesn't just massage away. This is tough scar tissue, and really, I would say that's probably dangerous. Like let's say hypothetically, you could even reach the fallopian tubes just abdominal. You can't, but let's say you could. I mean, I wouldn't want someone pulling and tugging and tearing. Like you could cause bleeding, and so I would say that is a terrible idea.
Agree.
Okay. Then I saw another one with somebody saying, well, I had this issue and I did a fertility cleanse and then I got pregnant. So would you recommend a fertility cleanse?
Is this juicing? What is a fertility cleanse?
So this is how you kind of know it's sketchy, right? I mean, she won't tell you what the cleanse is. You got to send her a DM.
Oh,
and then you have to sign up and pay for her fertility cleanse that helped her get pregnant.
Yeah. So unfortunately, and this is kind of a hard pill to swallow sometimes for patients, but tubal dysfunction really is not reversible. It's just a fact of the matter. Like I said, your tubes are just too fragile that once the damage is done, it's pretty much done. I don't think there is any sort of lifestyle regimen that you can do to undo scarring of the fallopian tubes, unfortunately. I wish there was. This is what I always tell patients. If there's an easy answer out there, I promise you I'd be telling you to do it.
Yeah.
I would love for there to be a cleanse that could clean out your fallopian tubes. It's just not the case.
So really, unfortunately, you have to be on the lookout for sketchy people. And really the biggest red flag is if they're recommending something to you that your fertility doctor has not recommended to you and they're charging you for it, I would be very cautious and careful about that.
Yeah. I think the problem is also like many of us, when we're looking for solutions to what's going on with our health, is we do want to find maybe a natural way or something that we consider that, might be more natural or homeopathic and things like that.
Yeah.
And so then these people really target that desire in us to find solutions like that.
Yeah.
And there may be, some solutions that we do offer patients that are considered more natural, but, we make sure that they're evidence-based.
Yeah.
Right. So just exactly as she said, if your doctor's not telling you, it's probably not something that has really been vetted.
Yeah, absolutely. And then I did want to mention surgery. So back in the olden days, before we had IVF, granted, there were people that did surgery trying to fix fallopian tube blockage. And sometimes it would work. But when you compare to IVF works so much better. And the problem is, even if they could unblock your tubes before, if you were trying to get pregnant, again, you would be at actually after tubal surgery, much higher risk of having an ectopic or a tubal pregnancy. And so because of that, although surgery technically could be an option, the vast majority of people are moving on to IVF as a treatment that has better success and lower risk to the patient as well. And really when I'm saying this, I'm meaning, let's say you tried Clomid IUI cycles, let's say you tried 3 times, it's not working and you're moving on to more aggressive treatment. Really, most people would move on to IVF rather than surgery. Because what I've seen sometimes if people do surgery too, is they try surgery and then it didn't work and you still have to do IVF. So it's like,
and surgery can be expensive too.
Oh, for sure. Yeah. Yeah. And risky as well. Okay. Well, should we wrap it up for the week?
Yeah.
Okay, great. Bye guys.
Bye.
Thanks.